Welcome to Rural Health Today. I'm J.J. Hodshire, President and Chief Executive Officer of Hillsdale Hospital, and this is a podcast where we connect you, the listener, to what really matters the most in rural health. I'm thrilled to be in the studio today with a very special guest, Dr. John Crongeyer from Modus One Health. Modus One Health, we're going to talk about that in just a minute. It sounds pretty awesome. I love the name. It really does. And we're going to see if you created that name or not, but we'll find out. So first of all, let's talk a little bit about your role at Modus One Health, and then what we would like to extrapolate out of that for our listeners who don't know you is background, a little bit about what you do, about what your company is, and why'd you choose the field. And then I'm going to ask you something special, which is tell us something neat or interesting about yourself. So let's start with a little introduction to the listeners who know nothing about you.
Okay, great. Again, thanks again for having me. This is a really great opportunity. I'm CEO of Modus One Health, as you mentioned. I'm based in Atlanta. I'm a physician leader and founder for our organization. And we've been going at it for about 11 years now.
Yeah. So physician leader, I've read some of your background. You were not always a physician, obviously.
Right.
You did some other work before that. You chose to become a physician. And was this a life calling? Was this a passion of yours inspired by someone specific? Do you mind sharing that story?
Yeah. So actually, I was the first physician in my family. So, relatives who were in the military, relatives that were FBI agents, and some really cool and important stuff, and a lot of attorneys. But there was no physician, and I was always kind of naturally drawn to science and medicine. Pre-med in college, really thrived with all of that coursework. I was interested in it, and neuroscience in particular. And, I just decided early on I wanted to go into neurosurgery, in fact, was my area. So I went to Johns Hopkins for medical school. I did brain tumor research, which I loved, worked with Henry Brim, their chair there, and fascinating work. But at some point I wanted to broaden and do something different. So I never really fully left medicine. I was always working in and around medicine, but I went and got a law degree, as I'm sure we'll talk about.
Yeah, I knew about your law degree.
Yeah.
We'll talk about that in a minute.
Okay.
But wow, that's amazing. Neurosurgeons, unique and certainly highly sought after. And you chose instead of still practicing, is that correct? Are you practicing somewhere?
No, I left early on.
So you left early on.
I finished medical school. I went into neurosurgery residency in Florida, the state where I'm from, down at University of Miami, Jackson Memorial.
Yeah.
Completed my internship training and all of that. But then I wanted to go off and change. So that's early on, and made that change in my 20s, went to law school. Yeah. But stayed, as I mentioned, with healthcare. So I was doing healthcare policy-related projects in law school. I went and worked a semester in AIDS clinics abroad in Brazil and South Africa and things of that nature.
Incredible. And what area of law were you particularly studying?
There was kind of a healthcare focus.
Good.
But and then I came to Atlanta in the early 2000s, worked for a large firm there, and was working with Emory Healthcare or Grady, our public hospital there, and doing that. So I was always around medicine even after leaving.
Well, that's incredible. So I'm assuming that's your fun fact, but maybe it's not. Do you have any other fun facts about yourself that if the listener was to ask, well, let's get to know this guy a little bit more. Any fun facts? Do you?
This has nothing to do with medicine at all.
It doesn't need
to. I had the luck or the pleasure in the 2000s of knocking out the reigning champ in the World Series of Poker.
Get out of here.
So No Limit Hold'em was my game. Still love it. I don't get to play as much anymore. But
you were a national champion?
No, well, I wish it worked that way.
Oh, okay. It doesn't.
Just because you beat the last year's champion doesn't mean you win. But I knocked him out.
You knocked him out. Well, that had to feel pretty good.
It felt great. I had ESPN there, and they were covering it, and hand almost played itself. I can't say it was anything masterful, but we got all in, and I got the better of that.
So $28 million later, you got the purse and the...
I wish I had his take from the previous year. I think he won $12 million the year before.
Oh, my goodness. So, is that right? That's incredible. Well, that is an interesting and fun fact. But your background lends to a lot of professions, a lot of work. They all obviously streamline up. I'm assuming that we'll have some time to talk a little bit about how it all integrates together.
Sure.
And I'm really excited to talk about that. But why don't you give us a brief overview of Modus One Health, too? I mean, what is that? And give our listeners kind of an idea.
Sure. For anybody familiar with clinical documentation improvement, CDI, and I think most people in the healthcare space are aware of it one way or the other. But we do things a different way. We are a physician-designed and physician-led system for CDI. And so, as I said, based in Atlanta, but we're doing national work, helping health systems, big and small, and providers do a better job painting an accurate picture of their patients, severity of illness of their patients. And that, as you know, is so crucial for good clinical care, because a misdiagnosis sometimes is not just something in the chart. It could be the difference of life and death.
It is, absolutely.
All hospitals now, especially prospective payer systems, they rely on an accurate picture to get proper full reimbursement. And then all the quality metrics come to it. So it's really integral across the spectrum.
Yeah. I love your physician perspective, because you first start with the right thing, which was the patient. You started out with it's right for the patient, obviously identifying any gaps in care. And then secondary, I'll put on my greedy administrator's hat, and we have to get paid for what we do. And we have to make sure the documentation is correct to the appropriate level of care in which we're administering, and to make sure the physicians are documenting that proper care, not only for the wellness of the patient, which is primary, and I appreciate you saying that, but also for the sustainability of the hospital.
Right.
And do you find that when hospitals do not have this documentation, you come into those places, it's probably like a revolution to them, isn't it?
It can be. I mean, there's a lot of myths too, because, with providers are understandably at times jaded about technology solutions or people talking about documentation. And rightfully, after years of sort of being burned in different ways, they view it as another burden, another thing they have to do. They have to write more, chart more. And what we try to really promote and teach is, no, that's not necessarily the case. Sometimes less is more. A long-winded, meandering note all about a patient's pretty obvious heart failure might not really advance the ball at all. That's just writing for writing's sake.
Right.
There's oftentimes there are diagnoses not being made at all, and no one's commenting on those in the chart. And so, things can be succinct, they can be evidence-based, and very direct. And that's really the key to saving providers time and rework.
Yeah, great strategies put in place to help patients, providers, and practices and/or hospitals. So, if you want more information on the opportunities that can be brought to you by Modus One Health, we'll make sure that is in the show notes for today. So, today we're talking about strategies for thriving as a rural hospital. It's not easy to navigate rural health in its current state, but the purpose of this podcast is to address both the challenges of rural hospitals are facing today and the new solutions and pathways healthcare innovators are finding across the country to make this doable. Dr. Crongeyer is here to share his perspective and insight as a physician, as an attorney, as an entrepreneur. Wow, all three in one. And also a great card player, it sounds like. We'll talk about the legal risk of healthcare, strategic growth, and of course, what does all of this have to do with rural healthcare in America? So, Dr. Crongeyer, appreciate the background, appreciate the insight, and I want to highlight the role that you've had in many, many different fields. Obviously, healthcare as a neurosurgeon, you've been and are an attorney, you've had work in that area, now a business leader, executive, sometimes three in one. So how does each point of view contribute to what you're doing in healthcare? And I mean, have you interwoven those together for how you look at the patient today versus how you may have looked at the patient even in med school, or how you've looked at the patient as an attorney?
Yeah, I think really what we're doing now and what I really enjoy about our work is putting these things together, because, it's all about perspectives. And a lot of times providers are faced with all of these challenges, but of course they view things strictly from their side of things, and they might not fully appreciate the financial strains. They read about them in the headlines, but they don't live them the same way a CEO or a CFO does.
Right.
Or they might get frustrated with denials or compliance concerns. But of course, there are other folks in those camps that have their perspective. And I think one of the things to break down barriers is to not add to that polarization. When I meet with providers, is helping them at least understand. Like, for instance, they may be very frustrated with prospective payer rules. Why does
they're all frustrated?
Yeah,
who isn't?
Right. But you
explain to them the value of that, right?
Yeah, or at least there was some rationale. I mean, why
at some point?
Right.
Yeah.
There had to be a reason why there's a little bit more reimbursement for certain conditions.
Correct.
Because maybe on 100 patients or 95 out of 100
Yeah.
patients, it seems all subclinical and it's not going to matter. But for 5 patients who have that condition, things are going to go south in a hurry. And there are going to be a lot of costs imposed on the system. So if providers never pay attention to those diagnoses, or they only pay attention to them when things have gone really wrong, that's a losing
It
proposition.
is a losing proposition. You're right. Absolutely. And everyone suffers in that proposition.
Absolutely. I mean, the analogy I'd make is it's like only charging auto insurance to somebody who has an auto policy when there's an accident.
Exactly.
Well, that's not how it works.
It's not how it works. Absolutely. Well, I like your perspective on that. Let's talk a little bit about risk management, because I'm sure that plays a big role in your field, especially as an attorney, and minimizing, some type of legal charges that could be filed against a hospital through malpractice. Proper documentation, though, that if it's not documented, it doesn't exist. We say that in this industry, right?
Right.
But at the end of the day, there could be a great value added to proper documentation clinically when it comes to the court of law. Is that correct?
Absolutely. I mean, the best defense, people say that the best defense is good documentation, but I'd go a step further. The best defense is good clinical care, good diagnosis.
Great
now,
point.
ideally, once you've had the diagnosis in your mind and you're treating the patient accordingly, putting it somewhere in the chart. But if you had to pick, and we even being in the documentation space all the time, if you had to choose between good care and good charting, of course I'll take good care. But usually they go hand in hand. A doctor who's actively thinking about a patient's sepsis diagnosis, usually somewhere in one of their notes is going to comment on it.
Yeah.
The bigger problem we see nationally with omissions is busy providers are taking care of a chief complaint.
Yeah.
But some secondary condition crops up that might become the biggest thing of that patient's life.
You're right. Absolutely. So how do you marriage all that together? I mean, what would you say to the physician listening today? What needs to change, I guess, from your perspective, on how hospitals navigate legal and compliance and risk? If the physician's listening today, what can he or she do to help reduce some of that risk? And what processes would be in place for them?
Well, I think one of the things is for physicians to kind of reassert primacy. I mean, we're still in a world where the clinical diagnosis and the provider has the final say.
Yeah.
But oftentimes, because of that polarization I mentioned, they're sort of working in a silo. They don't really actively talk to the coding teams and the CDI teams. And so what ends up happening is this kind of never-ending cycle of providers charting, billing and coding people, interacting with them after the fact.
In real time, though, right, is what the importance is, right?
In real time really helps, but after the fact also helps because, if a mistake's already happened, and we do this all the time with our work, we will monitor what just happened in the last month, balls and strikes, what was done correctly, what was missed. We're not going to fix those. What we can do is take 10 errors from last month and prevent 100 more just like it in the rest of the year. Yeah. And so getting those units really talking together, the physicians, if you don't have a standard, nature abhors a vacuum, as they say. You've got to have a standard. So physicians would lead, instead of just being bombarded with queries and questions about their patients, they can say, here's the standards we're following. And coding team, I want you to know what standard we're following. And CDI team. And once you get everything synced like that, you're going to have a lot more efficient process.
Yeah. So, Doc, here's the deal. I've had a lot of physicians tell me in anger, coders aren't going to tell me how to do my job. I'm not going to be told how to do my job. How do we bridge that gap of that mentality that it's someone telling them they have to do their job versus we're all working together for the best solution of the patient? How do we bridge that, though, in today's world?
Well, I think the real key is to realize it's not a 100-0 proposition. So getting a little bit of open-mindedness. They're not going to tell providers how to do their job. And by the way, that wouldn't be compliant if they did.
It wouldn't be.
But I think what can't be reflexively the response by providers is every question or query I get about my patient with altered vital sign, I'm going to just say no or shut down or deny it. Maybe some portion of those legitimately were a septic patient. And by the way, maybe it's a patient that if they made that sepsis diagnosis with or without the help of a question or a query, that might help the next provider coming on service the next day be a little more attentive, a little more aggressive with fluids and antibiotics, maybe utilizing the golden hours of sepsis, and you might save a life. And you might improve somebody's outcome. So I think getting providers to realize there is some value to those things. If they don't think that they're being efficient enough, then again, going there and meeting with them, or this is really what the role that Modus One does a lot of times is we work hand in hand with the providers, and we also try to get the CDI and the coding teams all literally on the same page. So they're not sending out so much background noise and queries that are not really well thought out to really refine that. That's one of the goals.
Yeah. So you led right into the question. Let's talk about how does Modus engage in this? I mean, you don't send 5 people down. I mean, this is a EMR support system, EHR system. It's an add-on. Explain to us how it all works. Are you compatible with EMRs? Give us
Sure.
Take me from ground zero.
Well, the great news, and it's relevant to rural health systems, is yes, we can work. We're sort of EMR agnostic. We can work with any EMR, whether it's Epic, whether it's a Meditech, you name it. Cerner.
The mom and pop shop.
Okay,
so some of those exist still.
Pretty much any one that allows remote access. Which in this day and age,
pretty much everyone.
Pretty much everyone.
They have to. Yeah.
And so our review teams and everything else can get in those. So the great news is this is where a rural hospital. For instance, tomorrow I'm going to be down in southern Georgia at a hospital kicking off. Our team already has access, read-only access to their charts. We can go through it, we can review it, we can data analytically figure out, as well as chart review, gold standard chart review with providers involved in the process, figure out where the misses were, not to be critical, but to figure out where the opportunities are. We can literally figure out in terms of quality metrics where it's hurting, monetary losses, you name it. So you got to put numbers around it. When I go to hospitals all over the country and you say, do you have an accuracy gap or documentation gap? They all say, sure, to some degree. Well, how big is it?
Don't know.
I don't know. Well, who's the worst? Who's your best documenter? They have no idea.
No idea.
It's all anecdotal. They might say, well, I think so-and-so is the best doc. That's more based on how they view that person overall. It may or may not be on the documentation. So we put numbers around it early on and say, now we've got baseline. And every month thereafter, you're never going to get there with a one-time audit. We are going to score, we're going to evaluate, and we're going to send that feedback loop, that information back to the providers constructively. Here's what was missed last month. It's okay. You're busy. You did a great job taking care of your patients. But here's what was missed that passed your workflow, And maybe, by the way, if we can shore these up, it'll protect you medical legally. Yeah. You'll get less queries. You'll save more time. The hospital financially will perform better.
Everybody's happier.
It's a win-win.
So build us a Gantt chart. All right, let's talk about I'm a hospital CEO and I identify we've got an issue. Or I don't know if we have an issue, but I need to find out if we have an issue. So I reach out to your company and I say, all right, I need to talk to you. We have the conversation. I feed you charts. And so do you review those charts and then come and give a recommendation like, hey, we witnessed that you had this fallout, that fallout in this area. Build the Gantt for us. And then let's say that I'm ready as a consumer to say, you know what, let's do this. Does it look like it's a daily commitment? Is it a monthly commitment? Is it a yearly commitment? You know, how often are you involved in the campus? What value added is your company going to give to me to ensure that?
Yeah. One of the great benefits that our clients tell us is our rapid ramp up, because usually by the time somebody's reaching out for help,
it's rough.
They've got problems.
They got problems.
And so they don't want to know that they're going to get benefits 2 or 3 years from now.
Sure.
So what we do is, because we don't have to install any technology on their system, it's a simple flipping of a switch and getting remote EMR access, as I mentioned. Within a matter of a week or two, we have that access. We're up and running. We're pulling data. We're doing reviews, and we're data analytically. We have some smart, really great data scientists and machine learning that we use so we know where to look. And so it's a modern process. It's not just we review everything hoping to find something.
Right.
So it's a driven process with the data team and the clinical team together, and we're reporting it back to the providers. Now, back to your question about the great thing for them is it's leveraged. Their providers need to give an hour of time at the beginning. Once they're onboarded, they know who we are, what we're doing, what our reports look like, and what they're intended to show. Every month thereafter, they have to spend 5 or 10 minutes to look at the report, see their name.
Yeah.
They will literally see a score, a diagnostic accuracy score. Providers aren't used to getting that. But what's great about it's the adage of what gets measured gets improved. They see that, human nature takes over. If some provider gets an 85% score, what's their nature? Are they going to worry about the 85%? No. They're going to go looking for that 15% and see, what did I miss? Who is Modus One? What's this about? But once they look at it and they see objective medical standards show that a patient had a condition and they didn't diagnose it, no one on the team did. It's okay, hopefully in that case. But that's a learning opportunity. And it doesn't take that process happening too many times with smart, well-intended providers who care about their patients and care about the welfare of the hospital. They won't be making those the same degree in month 2, 3, 4, 5, 6.
Yeah. Competition in healthcare is it's good. And one of the things that we did years ago is we heard this legend about cut times in the OR, that people weren't achieving their cut times on time and that they were arriving late, and, wheels in, wheels out was difficult. And everybody had their assumptions that, Dr. So-and-so was the best and Dr. So-and-so was the worst. We started posting the cut times, and it was miraculously, to watch the physicians scurry and identify, wait a minute, I guess it wasn't who I thought it was, and I guess it is who I didn't think it was. And it created such a healthy competition to make sure that they were in the case on time, because it became competitive in nature. And I can see where this type of reporting could be very positive in that nature. But one of the things I wanted to ask you, how do you have those tough conversations with those who fall out? Because are you helping the CEO and the VP have the conversations about, listen, we've reviewed your documentation, we've scored it for the past 2 months, you've been here, we really need to get you here. How is that played? And then that's part one. All right. Part two is put your legal hat on. Are there hospitals now that are building contractual agreements with physicians that have these type of metrics in them? So let's first start with, how do you have tough conversations? Second, how do you enforce that? And how do you build it really and just hardwire it?
Yeah. Well, the tough conversations part, I would have expected, I've been in the CDI space for 15 years across 2 companies, and they're not as many as I would have thought.
Really?
Because there's integrity in the system. What providers have gotten jaded about is, if some company that does pure data analytics, we do a lot of data analytics, but if you did pure data analytics and you just tell a provider statistically you're not meeting certain benchmarks, your patients are staying in the hospital, what is their reaction overall? You don't know my patients. My patients are sicker. They're different.
Higher acuity.
Right.
You've
heard it all.
Just this morning. I got told all that.
Right. But when you come at it and you really pull back the veil or the curtain, and when you get down to there and say, no, we've looked at your patients, MD to MD, multi-level review process. Look, this patient's creatinine went from 1.2 to 1.9. This patient had acute kidney injury. We're not saying they went into kidney failure, but they had acute kidney injury. And that was relevant. It has an impact on severity of illness for that patient. And there's many other instances like that. Then all of a sudden they sit back. They say, okay, now I understand Modus 1 better. I understand the physician-to-physician approach of it. So it's got to be elegant. It's got to be relevant. It's got to be verifiable. And that's where we get the buy-in from them. And also, we also have this role, and especially a lot of hospitals don't have the resources to have physician advisors, or at least not full-time or not poring over charts. We kind of get to serve that role for them. We can help them. So I'll give you one example. A cardiology practice years ago was worried about CDI and saying, if I chart these conditions on my patients, it's going to look like complications.
Yeah.
And that was a myth of theirs. They didn't fully understand how the registries of complications work. So what we explained to them is, no, you've got it upside down, well-intended, but upside down. Charting these things will help give you more credit for managing sicker patients.
It's true.
The complication registry is auto-firing off of data that's coming through in the charts. In other words, you can't stop that.
No, you're not going to.
But you can put it in context.
Yeah.
It's sort of like having a 10-2 record in football, but you're not getting credit for playing Alabama and Michigan.
There you go.
You've got to risk adjust it.
Yeah. Incredible perspective. And, certainly in our industry, I think when we take off, some of the nomenclatures and some of the stereotypes and some of the barriers that we often put in place, and really come down to analyzing what is best for the patient and getting that documentation and what is best for the organization, we find that the outcome is a happier physician in the end. They can do their job better. They have more access to tools. And it sounds like exactly what your company is doing on a daily basis. So I want to talk about something else. I want to talk about growth, okay? And for hospital executives like me, Growth is our only hope in today's world, right? And you're working with hospitals, rural, metro, you see it all, but our rural communities are suffering. And so, we don't have the infusion of young adults coming to live in these communities who are building up a base, and we're stuck with a population. And I don't want to say stuck as in a negative mentality, but it's really just this truth that we have an older population that's getting sicker, right?
Right.
And so we're faced with the challenge of how are we going to grow this organization beyond maybe just the parameters of the local community, and how do we expand services? But before we can even get to growth in the community phase of it, growth has to be looked at inwardly. And so with so many rural hospitals operating right now in the red, many are vulnerable to close. It is since 2010, we've lost about 180 hospitals in this country. This year alone, we've already lost almost 16 total. I think we have one that was on the verge, so 15 total hospitals since January 1st. Okay, it's slated that if this legislation occurs, that we'll lose 800 more hospitals. Majority of those will be at immediate risk of closure. A lot of challenges. So what hospitals look for is growth. We have to look at growth. So how do you equip an organization to grow? What types of steps should be taken? What strategies have you seen succeed in rural communities, specifically in the area of growth? Can you marry CDI and growth? Is there such a thing? I don't know. Talk to us about growth.
Yeah.
You're seeing you fly across the country.
Yeah.
You're going to be in like 10 different places in the next 2 days. The stories have to be similar. Maybe not. Tell us.
No, there's a lot of themes to it, and what you said about Medicaid cuts and what's going on with small hospitals, I'm hearing about it all the time with our clients. Tomorrow, I'll be on the ground with a rural hospital kicking off, and they're acutely concerned about it. Of course, whether all of it comes to pass or not, they're already struggling, and that will only exacerbate it. So, they have to do something, and I really can't stress that enough. And doing something in the revenue space means taking action. And with CDI, again, as you and I talked about earlier, this is one of those rare win-wins. This isn't like buying an MRI machine because it's a little better qualitatively, and you hope long-term it's a good thing for your patients. But you can get a very high return on investment. For us, when we go to hospitals, we figure out a way to leverage our national scale to give a greater than 10-to-1 return on the investment.
Oh, wow.
And we'll also even structure things with hospitals to where, we take some risk ourselves. And if we can't help them perform better, then we're going to bear that. So it's not on the shoulders of the hospital, because I think there are situations, unfortunately, where there are vendors and organizations, they want to sell whatever the services they're selling, but yet for the hospital, the year ends and they lost money. It got flipped upside down.
Yeah.
So I think what strategies can hospitals do? They can be smart and simple and go for what they need. If you've got a revenue problem, then go right at the revenue problem. And the only way, as you point out, you can't manufacture necessarily more patients.
No.
So hospitals have to do better with the patient population they have. I'll give you one very tangible example. Observation stays versus inpatient stays. Huge problem, because a lot of hospitals that I go to, they're getting more and more observation stays.
Absolutely.
Right? You're
100%.
probably feeling this.
Every day.
Yeah. And less and less inpatient admissions. And the revenue discrepancy there is tremendous.
Huge.
But I will tell you, the pendulum swings too far sometimes.
It does.
The denials have driven some providers and some hospitals and utilization review folks, well-intended, to push them into ops units.
They do.
And then they think, well, I'll come back and I'll really reevaluate.
No, you won't.
No, it's that biase that you have. Once you start down a path.
It's done. Yeah. That's right.
So yeah, you're living it, and I'm seeing it with all of our clients. And we've taken some clients that had 40 to 60% of their ob stays should have been inpatient stays, could have been justified medical necessity. Help exposing that, again, with this combination of smart, modern data analytics, chart review, showing them time in and time out, serving that physician advisor role, and within a matter of months, rapidly bringing down appropriately, compliantly, their ob stays and bringing up their inpatient stays. And I just had a call this morning with the CEO who was just, he switched hospitals, and he brought us into his new hospital right out of the gate.
Right out of
He's
the
like,
gate.
we've got to
Yeah.
do what you did one more time. Let's do it at a new facility.
So you've got that going on in the background. Conversations are happening. Growth. When you go to a rural hospital today, what are the signs of a healthy rural hospital, would you say?
Well, I think one of them is looking for new ideas and change. Even if they had a pretty good year, even if they've done better than their peers and they've gotten awards and so on, not getting complacent, not being satisfied with that. You can celebrate the wins with your team and give credit to your team as a leader, but you've got to constantly, the rules are changing, like you just said, whether it's Medicare reimbursement, Medicaid, all of these rules, the whole milieu that they operate in is changing all the time. So staying agile, and it's actually one of the things that small hospitals, it's one of their advantages they have. We talk about all the challenges and disadvantages.
We can move on a dime right now.
Can move on a dime.
Yep.
You can't do that. Big health organization, I can't tell you.
A year
they go
later.
through bureaucratic cycles.
It is.
Yeah.
And a year later, maybe you've got your first introductory meeting.
But a lot of small hospitals, despite theoretically having that agility to make decisions and even undo decisions if it's a bad decision, pivot, they don't do that. They tend to study something for a long time. It's sort of in the DNA of health leaders in many cases.
I agree. So let's talk a little bit about success, because your company's had a lot of success. Do you have, not naming any of your clients, of course, but do you have a favorite success story of what you've done with one of your clients and you've turned around potentially and even saved a hospital? Is that too grandiose? Do you feel that you've potentially been the difference between a hospital shuttering their doors and not shuttering their doors?
Well, I would say at least we're in a top three factors. I mean, I think, a lot of times these are multifaceted issues, but I've been told that we are crucial to the financial survival of some small hospitals. Now, you're right. When you get to mid-sized systems, and that's work is very rewarding as well, is the entrepreneurial, the growth, mergers and acquisitions. There's excitement to that, and they make a lot of headlines. But a lot of times, if we're being honest, I know those systems are going to be in business with or without us. They're just their business is going to do a lot better, hopefully, with what we're adding to the mix. But for hospitals, it literally can be that difference of surviving or not, and coupled with some other good, smart decisions.
Yeah. So I'm assuming that you've had some success stories that are your favorite. Do you have any particular ones you can share where you've increased, the days cash on hand by a few days or anything of that nature?
Well, I can give you a couple of different ways to look at it. From a revenue standpoint, we've got one small hospital comes to mind, struggling on their budget, upside down for a long period of time, and tore the Band-Aid off and said, we're going to do something different. And they got past the defensive voices, because you know what they are.
I sure do.
And people say nothing's going to work. We've done everything. We've tried everything.
We've done that. That won't work here. Oh,
right.
Yeah.
Got to do it differently. Got to do it better. Execution is key. We have a hospital where they went from negative to $3-4 million profit every year. So huge change on their budget. Now, maybe for the Tenet or HCA of the world, $3 or $4 million ain't going to do anything. But for a small hospital,
it's a game changer.
That's salaries, that's jobs, that's equipment, that's survival.
It's pay rates, absolutely.
The other one I'll mention is on the quality front, because it's not all about, it should be about good patient care. And of course, the business side is part of that. But these quality metrics are ever increasingly important. One group we worked with on their sepsis mortality, they looked worse than the national average. They didn't think they were worse than the national average in managing sepsis, but they were, on paper, they were looking that way. And by just doing a better job with what we've talked about, better diagnosis, better risk adjustment, they went from worse than the national average to 30-40% better than the national average. They're in top of their class in their health system. And they've in that one division we work with, small hospitals, critical access hospitals, medium-sized and large ones. But so they took a whole group across 8 hospitals and significantly changed that crucial quality metric. Yeah.
And then there's the others. So, you talk about finance quality, but then, when you have risk avoidance and you have fruits of your labor that you may never, ever hear about, it's in the proper documentation of the clinical diagnosis of the patient, which could prevent a lawsuit. and you'll never see that probably in your career in terms of knowing, oh, we brought in, these experts, and as a result of that, we didn't have this lawsuit. It's going to become organic almost with the process that you're implementing. So quality, risk adverse, you look at, documentation, you look at what's really best for the patient, and the community wins. Everybody wins. But let's say you've got, I have a lot of my colleagues, CEOs that listen to this podcast across the country, and I hear from them. And what do they say to their CFO who's going to say, no, how do you have that conversation when he goes, been there, done it, not going to work, these are not, and they almost take it personal whenever you bring up finances to a CFO and say, we need to look at this differently. What are we doing wrong? How do you break some of those barriers?
Yeah, well, with the limited time you get, and you've got to really use it well. And so one of the things that we try to do if we're encountering some of that resistance is showing them something right out of the gate that we know they don't have. So for instance, if we have an example, of course, we'll blind the names and so forth, but we'll literally put up a leaderboard from another client and say, names are gone, but do you have this leaderboard from most accurate, who's your 100% diagnostician down to 60% with all of these key metrics that matter for your financial and quality performance? And if you have that, then maybe this is not worth doing.
Right.
But without fail, if they're being honest,
they're going to say no.
They say, no,
Parts,
how would you even begin to do that?
Yeah.
And now you have their curiosity.
Yeah.
You finally have them saying, okay, maybe you do have something new to give.
Yeah, absolutely. We could talk for hours, and we're on. We've already extended our time. I've already gotten the look several times, but it's really been a great conversation, and I hope to have you back. Maybe if you can't fly here and get in the studio, we could do it remotely for an update on, my hope is that as you integrate more into Michigan, you're part of the Michigan Hospital Association now. It's a board I serve on, and we're glad to have our endorsed business partners like yourself. So that's always great, and you'll have some opportunity here in a few weeks to actually rub some elbows with some of the leaders in healthcare across Michigan. But really, it's about the value added to the patient care, the organization, and the sustainability in the whole hospital infrastructure. That with the looming threats of Medicaid, what steps can those hospitals take to redefine their mission, to identify new ways of growth, organic or otherwise, and to look at existing processes like this and make some type of adjustments that could be a winner. And I really think that this could be one of those things that could work for them. So it's been great to having you on the program today. And every segment we close with, we get what's called the Rural Health Recommendation. And for every guest that we have on our show, we'll ask them to contribute a recommendation on rural life and rural healthcare. And you've probably traveled many rural areas. In fact, you were just sharing a story of flying into a rural area, and pretty much the airport shut down on you, and you couldn't even sleep there. I mean, it would have been nice, but you couldn't. Took a ride with a local farmer, and the rest is history. But at the end of the day, you've been in a lot of places, you've seen a lot. What sage advice or information could you provide to someone who maybe is new to the business? Maybe it's someone who's just starting out in healthcare, like what should they be looking for? What should they do? And advice on how to thrive in healthcare. You've got the experience. Tell us what's some advice you would give to the new leader rising up. Should they be curious? What should they be doing? And then we post this on our podcast website, ruralhealthtoday.com, of your recommendation. So, Dr. Crongeyer, tell us, what is your rural recommendation?
Well, I think taking decisive action, as we talked about earlier, small facilities, rural facilities have that agility. And of course, not action for action's sake. You want to be smart. And that's kind of dovetails the corollary to that is doing things that are smart and simple, sort of the KISS principle. And in this day and age, for instance, AI, it's all around us. Everyone's talking about AI. Oh, yeah. But if you need a certain intervention, you need a certain service, maybe it's what Modus One does, maybe it's another. Think exactly about what you need, very specifically. Look for that network, find out who already's got it. Maybe it's the Michigan Hospital Association and they're recommended. Maybe they've already done the diligence and vetting, and go directly after. But make sure going in, you know where you are, where you want to go to, your KPI, whatever your metric is. Because so many, I see leaders getting caught up I've literally seen RFPs. Hey, we need AI.
Oh yeah,
and they'll just say generically
I know.
AI in what
like
area?
It's like AI,
Secret
come
sauce.
on. Yeah, exactly.
Right.
Yeah.
And it's like, well, if you haven't really thought about how you're going to use it and who's going to be receptive to it, you might just be worsening your
For
budgetary
the sake
problems.
of it, right?
So I think just going in a very simple, direct approach and eyes wide open.
Thank you, Dr. Crongeyer. It's been great to have you in the studio today. We look forward to having you back at some level into the future. And thank you to our listeners for tuning into Rural Health Today. Catch our next segment, Rural Health News, to stay up to date on the current state of rural healthcare every Monday, wherever you get your podcast. Don't forget to check out our latest updates and resources from Rural Health Today at ruralhealthtoday.com, and make sure you've subscribed to the show so you never miss an episode. Until next time, remember the power of rural.
Thank you for listening to another episode of Rural Health Today, the podcast where we connect you to what really matters in rural health. Rural Health Today is a production of Hillsdale Hospital in Hillsdale, Michigan, and a member of the Health Podcast Network. Our host is JJ Hodshire, our producer is Kirsten Newlon, and our audio engineer is Kenji Ulmer. Special thanks to our guests for sharing their expertise on the show, and also to the Hillsdale Hospital marketing team. If you want to submit a question for us to answer on the podcast or learn more about Rural Health Today, visit ruralhealthtoday.com.